Hello.
We are going to go ahead and get started right away. My name is Dana Shive. I am the Director of Communications and Membership. Today we have Michelle Bell here with the Patient Safety Authority, and we are going to be discussing patient safety events. This presentation is worth one contact hour. So I'm going to quickly read the disclosure. Then I will turn it over to Michelle. And when she has finished her presentation, I will send out the survey in the chat. And then I will also email it out to everyone tomorrow. So disclosure, in order to obtain contact hours for this activity, full attendance to the activity, as well as completing the post-activity evaluation is required. That is the survey that I mentioned will be put in the chat at the end of Michelle's presentation and will also be emailed out tomorrow. The Pennsylvania State Nurses Association is accredited as a provider of nursing continuing professional development by the American Nurses Credentialing Centers Commission on Accreditation. So now I will turn it over to Michelle.
Awesome, thank you. I'm actually really excited to be here to talk about reporting, which I know is kind of a dry topic sometimes, but hopefully I can make it a little fun and explain some of the things that we have in Pennsylvania that make us unique and special in comparison to the rest of the world. So if you have questions that come up, feel free to drop them in the chat box. I'm happy to answer questions as we go or at the end or wherever it seems to fit best, but don't hesitate to do that. Also, if you want to go ahead and get your cell phone out, put your cell phone away when you're doing a presentation. And I actually want you to have it in your hand because we're going to do some poll questions. And to start with, 223. I got muted. Text 22333, and then in the text box you're going to put PSA 130, and that's going to get you into the poll everywhere. You should get a confirmation message from that text number when you text. So again, that's 2233 PSA 130. And for our first question, I want you to text in just a short response. What is the biggest patient safety challenge you have in your current job? And while you do that, I want to give you a little history lesson. So when we think back on patient safety and what the landscape has been for patient safety over the last 20-25 years, 1999 was kind of a turning point where we started talking more about patient safety and less about some of the quality, because quality had existed since like the 60s. You know, we saw things like Joint Commission and AHRQ, but really in 1999, we had the release of the Institute of Medicine report to Err is Human. And that really shone some light on the fact that we are actually harming people with some of the medical events that were occurring and the errors that are occurring. And it's a problem, and it's a systemic problem. And that title, To Err is Human, is very enlightening. Because if you think about it, we as humans all make mistakes. Every single day we do things like put our glasses on our head and then can't find them. So we have to go search for them. Or we use our flashlight on our phone to try and find the phone. You know, and we've done things in other parts of our life to make things safer using engineering and design. So if you think about like in your car, you can't take your car out of park once it's been started unless your foot is on the brake, because people would do that accidentally and knock it into neutral or into gear and go when they didn't intend to. And so saying to err is human, we need to make the system safer so that it's harder to make a mistake, really allowed us then to start looking at errors as they occurred differently. Because up to this time, it was really about who made the error and how we could somehow train it out of them. So if you think about when errors happen, is the solution in your facility to say, let's do some education and write a policy, or is it to say, let's take another look at this and see what we can do to make things safer? And I am not sure why my stuff is not popping up here. Hold on a second. Let me see if I can get it to sync. And I will reshare this. There we go. That's better. Maybe.
Michelle, there's a comment in the chat that says message on the poll is web voting has not been turned on for this poll.
Oh, well, this is showing up.
Okay, so you're getting the
You
responses.
guys see that? Hold on. I'm sure. Yeah, I'm not sure why that's not working. See? Okay. It looks like it's working. I'm not sure, or at least on my end it does. And then when I go to share it, of course, it does not. Let's try this again. Okay. Well, it flashed up. I promise it's a beautiful word cloud that shows a lot of concerns about fear of retaliation, staffing challenges, and none of that surprises me, honestly. So we did a really interesting survey about a year ago, and you probably all, as registered nurses, got an invite to participate, where we asked physicians, nurses, pharmacists, and respiratory therapists some questions about reporting across the state and their understanding of reporting. And we got a lot of responses. You can see there we had over 18,000 responses, and a big chunk of them, the majority of them, were from nurses. Also wasn't very surprising to me. I think nurses tend to bear the brunt of reporting in facilities, especially about patient safety. So let's try this again. With your phone, you should be able to text either an A or a B to indicate true or false. The healthcare facility where I work is required to notify my licensing board if I fail to report a patient safety event that causes harm to a patient. So this is actually true. So in 1999, we had to err as human, and in response to that, in Pennsylvania in 2002, we had a law passed called Act 13 of 2002, or MCARE, the Medical Care Availability and Reduction of Error Act, which is a big old giant thing that's hard to say, so we call it MCARE. And it did a couple things. It addressed the malpractice crisis that was going on in Pennsylvania at that time and established the Patient Safety Authority. And there's a lot of pieces to what all was in that law. As most laws are, there's always little things in there buried. But one of them specifically is that if you as a healthcare worker in a facility that's required to report by MCARE know about a patient safety event that wasn't reported, you can be then reported to your licensing board. Actually, I think it says the facility shall, which means they have to report that to the licensing board for their action. So I honestly don't know, since we're not on the board of nursing or within the facilities, as to how often this happens. I hope not frequently. I think most people are reporting things that they know about. But that is actually true. And when we looked at that, 78% of people knew that to be true, and about 80% of nurses knew that in our survey. One of the other pieces in MCARE Each facility that's required to report has to have a patient safety officer. So think about in your facility, do you know who that patient safety officer is? And do you understand what their role is within the facility? Because that person's a good person for you to know and for you to communicate with about patient safety concerns. I know during my work, I've found it's very interesting to go out into facilities and talk to nurses on the floor and ask them, where's the next error? Where's the next event going to be? Because they can tell you, they know what the problems are. And thinking back about to err as human and what we're trying to accomplish by improving the system design, then how can we then design the system to help reduce the likelihood of those errors occurring? So in healthcare, we've done some really amazing things and put some engineering design in. I know I talked about like cars, but things like free flow protection on pumps. It used to be if you opened a pump while an IV was running, the IV would just gravity drain into the patient. And now if you forget to put that roller clamp on, it automatically clamps it off when you open the pump. And that's because patients were harmed in that way. And we made it, again, harder to commit the error and easier to do the right thing in that situation. Whereas if you need to open it back up, you can. But the default then is that protective step. And we've seen this in other things. Think about things like the dose error reduction software on smart pumps or barcode scanning for medication administration. And there's new things coming all the time. One of the newest things that I think is on the horizon is RFID medication tracking, because we can include a lot more information about the medications in an RFID tag, a radio frequency tag, than we can in a barcode. So we're continuing to improve and continuing to evolve and continuing to do better. Your facility has to have a patient safety committee. Your patient safety committee has to have representation from nursing, from medical staff, should have other representation as well from your leadership, from your dietary, from different units. It has to have a process for you to submit reports about events internally that's available to you 24/7. There are also whistleblower protections. So that first slide when you guys said, I'm afraid of what will happen to me if I report an event, there's actually whistleblower protections built into MCARE that you can't be retaliated against because of something that you report in good faith. And then there's also this written notification that requires facilities to not just talk about events and track them internally, but when a patient's involved, they need to give written notification to a patient involved in the event to say, hey, this happened. So it really encourages that transparency and that communication between the caregivers and the patients, which is important for all of the things that we're trying to do with patient engagement and having them be involved in care. Healthcare is not something that happens to them. It's something that goes along with them existing. We're part of their life for a short period of time. They're the ones who need to live with it. Looking on then, like to the definitions of what's reportable, this is kind of where some of that legalese comes in that I said gets a little dry. But I promise I'll try and explain this the best I can here. When you look at what types of events you report internally, not necessarily everything is going to be reported then to our central database at the Patient Safety Authority. We have 3 categories of events that are reported to us. And you'll see here for an incident that it's an event, occurrence, or situation involving the clinical care of a patient in a medical facility which could have injured the patient but didn't cause any injury or require additional healthcare services. So this is an event, occurrence, or situation involving the clinical care of the patient and nobody got hurt. That's really, really broad. It's so broad that there's probably 100 things a day that could fit into this that you probably see during the course of your day. If you then look at serious event, a serious event is an event, occurrence, or situation involving the clinical care of a patient, but it's not something that could have caused harm. This is something that did cause unanticipated injury and require additional healthcare services, or it caused death. So these are those harm events. When I talked earlier about the reporting to the nursing board about failure to report in the facility, these are the things that they're looking at. What are the things where a patient got hurt did we not report internally? So those are the two clinical definitions of what's reportable. Now you'll see here there's no mention anywhere about an error. It doesn't say someone made a mistake. It doesn't say someone's to blame. It doesn't say someone's at fault. It says an event, occurrence, or situation. So there's no blame. We're not looking to place blame. We also don't, in these reports from facilities, collect any information about the patient's name. We collect things like age and gender and some demographics, but nothing that's like patient name or medical record number. Nor do we collect things like practitioner name, because we don't care. That's not what we're doing with these reports. The third category in the law are infrastructure failures. And infrastructure failures are things involving the infrastructure of a facility that somehow discontinue or disrupt service and could compromise patient safety. So those are like the three really, really broad definitions in the law. And one of the things that in particular that makes Pennsylvania unique is how broad these definitions are. There are, I believe, around 26 states and the District of Columbia that have some type of a statewide mandated reporting system. And of those states, most of them have a very, very short list. It's very similar to like the Joint Commission Sentinel event list or the NQF Serious Reportable event list. But most of them are not nearly this broad. Most of them focus very much on those harm events. And those harm events only make up about 3% of the total events that we receive at the Patient Safety Authority. So that means that 97% of the events that we receive into our database are things that didn't cause any harm to the patient. They're just potential problems. So when we look at our data, we get a much better, broader picture of what's actually happening at the bedside, because we're not having to wait for someone to get hurt to know that there's a problem there. So with all that in mind, again, you can text PSA 130 to that 22333 if you haven't already. If you already have, you should already be in. And just enter there, what percentage of events do you think are reported in your facility? So while you guys do that, I'll talk a little bit more about our data and the things that we see within it. So we're collecting information from hospitals, which includes acute care hospitals, critical access hospitals, LTACs, rehab hospitals, behavioral health hospitals, ambulatory surgery centers, class A, B, and C, abortion facilities, and birthing centers. So all those different facility types are required to report to us. So it looks like there's a couple hundred, 60, 50, couple 25s. The overall statewide average on this one was about 58.8, I think, when we looked at the total number. So just over half of events people thought were probably reported internally. And keep in mind, with those really broad definitions, this could be everything from I was walking down the hallway and there was a cord in the hall that was a tripping hazard, and I moved it out of the way. That's technically reportable as a potential issue because it's an event, occurrence, or situation that could have caused harm. It didn't reach anybody. It could be the patient was ordered 650 of Tylenol and they got a gram of Tylenol. Probably no harm to the patient. Probably not even going to have to do any big observation there, but that was technically a medication error. So things like that, where it reaches a patient and doesn't cause harm. So there's a lot of different types of events that could fit into all of those categories. One of the other things that makes Pennsylvania unique is then what happens to reports. So I talked about those three buckets and kind of what happens, like where they get split as far as what the definitions are. But if you look here, they all go into our central database. We call it PA PACERS, which stands for Pennsylvania Patient Safety Reporting System. And we love acronyms, obviously. And you can see here those incidents, those things that don't cause any harm, only come to us at the Patient Safety Authority. the things that cause harm, those serious events, come to us as well as to the Department of Health. So what this graph doesn't show is there really should be a wall here between our logos, because we don't share information to each other. Like they by that law have access to the reports. For serious events, we actually don't have access to the infrastructure failures that are submitted by facilities. Only Department of Health gets those. And again, that's the way that law was written. So when we're looking at events, we at the Patient Safety Authority are looking at those things that didn't cause harm and the things that did cause harm in the course of that clinical care of a patient. And those things all come into our database. And there's a whole bunch of stuff that happens to reports. Not every report follows the same path. Sometimes somebody looks at it and they're like, oh my gosh, I think there's a story here. And we'll call the facility and say, like, tell me a little bit about this. So it kind of goes through like a triage process, and then there's 18,000 different ways that we crunch all the numbers and data displays we can look at. We have a weekly meeting where we look at the things where there was high harm or things of particular note. And then all of that gets turned into information. So sometimes people say, you know, reporting is hard. Like it's hard to get people to like see the value in reporting because they don't see what comes out of it. But I can tell you, like, there's a lot of things that we do that come out of these reports. So if you go out to our website, we have articles. We have recommendations, which are more formal type of articles. We have tools on our website. We have our journal, which is completely open access. You can sign up to receive the journal electronically. It's free. If you are doing patient safety work and you want to submit an article, that's free. We don't charge author fees. It's completely open access because we want this information out to people as much as possible. We have our patient safety liaison team, which is every hospital or facility type that I listed a little bit ago. Every single one of them has a contact person on my team. And they're out talking to facilities and asking about the events and helping them with problems that they have or investigations, or even asking the right questions to really find out, like, what can we do to keep this from happening again? We do a lot of different education. So we can go out to facilities and do in-person education. We do things like this all the time. We have monthly webinars that my team does. We do other extra webinars just for fun because we love to educate. We're the Department of Outreach and Education, so that's literally what we do. The annual report is a good summary of like the data over the course of the last year. Excuse me. So there's a whole lot of things that come out of that work and those reports that really lead us down different paths. You know, many moons ago, we had done a project around patient wristbands because facilities had different colors. So we tried to create a group to standardize some of that. A couple years ago, we noticed a big increase in NG tubes and insertions and perforations, and we found out that there was a type of NG tube that was kind of on back order and hard to get, so people had changed their supplier, and it required a different technique for insertion. And we were able to then identify that because we were seeing the reports from the entire state and not just from one facility or one location or one department. So that's the benefit of the work that we do. And I strongly encourage you, if you've never been on our website, please go out and take a look at the abundance of information that we have. Whatever your favorite patient safety topic is, we probably have something about it. So let's talk about some specific examples. I know I kind of told you that the definitions are very broad, but think about, would this get reported in your facility? A delay in recognizing fetal distress that then results in fetal demise. And this is all part of the survey that we had done. We had, I think, 18 different scenarios that we put in the survey and asked people, like, would this get reported in your facility or not? And it looks like yes. At least everybody who replied to the survey or could reply to the survey said yes. What about this one? A patient slow to emerge from anesthesia, and so they're given a reversal agent. And again, that's just an A or B text, depending on. Okay, so maybe a little less, but mostly okay. So here's those 18 scenarios that we put together, and this was our team got together and thought of different situations that we would probably expect would be reported at least internally. Most of these are probably going to fit one of the definitions for reporting to the Patient Safety Authority, but they should have at least been reported internally. And the reason being that then the patient safety officer's job is to investigate all of these things and find out if it met the definitions or not. And there's a whole lot of nuance. And if you really want to talk about all of the nuance, I'm happy to do that offline. But I will be honest, it's like a 3-hour conversation, and I would bore you all to tears and never be invited back ever again if I got into it on this call. But here are the first 5. And the percentage of people who replied to the survey who said that yes, they would report that. So you can see there the delay in recognizing fetal distress, that almost 91% of people who responded to the survey said, yeah, I would totally report that. And they go down from there. A piece of guide wire broke off during insertion, and people said, we're just going to leave that there. It's going to do more damage if we try and take it out than if we leave it. A physician giving someone the wrong post-colonoscopy report. Permanent paralysis after a discectomy. I was surprised that was only 75%. I thought for sure that one would be a lot higher when we came up with that. And a behavioral health patient. Here are the next 5. A patient allergic to dairy who receives milk on their dietary tray. Sterile field contaminated during surgery. Respiratory treatment that was ordered Q4 given Q6. Patient just presented to ED with a headache, treated for migraine and discharged, but came back 24 hours later with an acute stroke, and urinary retention post-surgery, where they couldn't find the bladder scanner. And again, you can see the numbers go down from there. The bladder scanner one I picked because it was always impossible in the facility I was in to get your hands on the bladder scanner. Like I know it existed. I did see it, but it was never there when I needed it. And that's just sometimes how things work. But that's how you can then document the bladder scanner is unavailable, and you can document that pattern so that people can say, like, hey, this is showing up as a continued problem. Maybe we can fix that. And that one is an easy one to fix. You know, things like the patient being discharged after being diagnosed with a migraine is much more complicated of a process. But having the right equipment available is really so much easier of a problem to fix. Again, here's 4 more. When removing an IV dressing, the patient gets a skin tear, and they place a Band-Aid. After procedure, patient develops bleeding, so they have to go back to the OR. Expired chest tube trays found in the stock room. An air embolism noted during a cardiac cath that they were able to resolve with a dose of nitro. And again, you can see the percentages there start to go down. So I was actually surprised that expired chest tube trays in the stock room was actually higher than an air embolism that required additional treatment, because that didn't reach a patient. So you can start to see kind of that like surprising patterns, I guess, in some of these. And then the last 4 we had on there, ventilator reading loss of PEEP. The non-disposable exhalation valve was changed to disposable, and they took the non-disposable one out of service, but the patient wasn't harmed. Patient with no known history of allergies is given an H2 blocker and develops hypotension. Pharmacist identifies that the antibiotic dose isn't appropriate because of the patient's renal function, so they call the prescriber and get the order changed before the patient ever gets a dose. And then that patient slow to emerge from anesthesia, who's then given that reversal agent. And you can see that one only had 17% of people replied that yes, they would report that internally. Again, like I said, it's not hard and fast. Certainly I have a lot of questions about all of these situations that if someone called and said, Michelle, help me report this, that I would ask about any of them before I offered them any guidance. But I would expect to see them reported internally because they are all situations out of the norm that shouldn't be our normal operating procedure. So with that, of those 18 scenarios, only 6.3 of people who responded to the survey correctly identified all of them as being reportable, which is a little surprising to me, especially because so many of the nurses said, yeah, I'd report that. Yeah, I'd report that. But there was something in each of them apparently where they didn't feel as though it would have been reportable. So with that, why might someone in your facility not report an event? What do you think are the reasons that people say, it's not going to be something I would report? Looking at some of these examples, if you would report all of them, that's great. Why would someone else maybe think that they wouldn't need to be reported? Time, disciplinary concerns. So the time thing is really interesting because I think that is a huge piece of it. And this was a question that we asked in the poll, is why might someone in your facility not report an event? Like, what are the reasons things don't get reported? And a lot of them really came into, fear of retaliation, concerned about putting their name on an event report, and time. Time was a big one. And like I said, the potential number of these event reports that you could see during the course of a shift, really you could come up with a lot at the end of the day. So time doesn't surprise me as being a barrier. I think that said, if you look at the amount of time that it takes to actually do an event report, each facility is a little different in what the information they ask. But it shouldn't take any more than a couple minutes for someone who's at the front line to fill these out. If it does, certainly I encourage you to talk to your patient safety officer about the amount of information that they're asking. But for the purposes of, to start at least, I would want to know like where it happened, when it happened, and what happened. Just the facts. Tell me where things went wrong, and then I'll look into it later and try and get into like how it happened. So anonymous reports. I want to talk briefly about anonymous reports because I think this is a piece of the law that, again, gave a lot of acknowledgement to the challenges that come with trying to change the patient safety culture in organizations, and holding organizations accountable for the work that they're doing. So anonymous reports, there's actually a whole section in MCARE about anonymous reports. But if you are a healthcare provider in a facility where an event occurs that causes harm, so it has to be a harm event, you have to be a healthcare provider employed at that hospital or facility, and you report it, and you don't feel as though the hospital is doing what they're supposed to, or the ambulatory surgery center or whatever, you can fill out an anonymous report and submit it to us. We are non-punitive, non-regulatory. This is the only thing in the entire law that gives us any authority over facilities. In that, if you submit an anonymous report, then we tell the facility that we've received an anonymous report, and we ask them for a copy of their investigation. If they have not done an investigation, or if we get the investigation, we review it, and we don't think it's adequate, we can then have our contractor go in and do a review of that event. And the purpose isn't to try and catch someone doing something wrong. The purpose is to make care safer. Because remember, Department of Health has the regulatory authority that we don't. And Department of Health doesn't ever see those incidents or those non-harm events. Our whole purpose for existing is to look at the things that are happening in facilities and try and make patient care safer. So this is really unique because I'm not aware of any other state who has an anonymous reporting system like this, and especially not with a non-biased, non-regulatory, like third party like we are in the law. And this information, again, it's all on our website. If you are not a healthcare worker at the facility, or if the event didn't cause harm, or if you didn't report it internally, then it's not going to meet the definition for an anonymous report. And we tell you to then like submit a complaint to Department of Health. But as far as like our investigation then and the follow-up with the facility to make sure that they're doing thorough and credible investigations, this is what gets us in the door to do that. And we don't get a ton of these. I would say on average 1 or 2 a year. We don't get a lot of these. And I think it's because there's not facilities who are trying to cover up events. I think people are trying to do the right thing. I think people want patient care to be safer. And I think that they're making the effort to do that. But this does kind of give that extra level of insight into what's happening in the facility. The other thing on here, you'll see it does ask for your name. You don't have to put your name or contact information. And certainly if you do, then that's not information that gets shared with the facility, which is why it's called anonymous. It would just be so that if we have questions, we can follow up with the reporter to ask them more about it. So with that, I know I mentioned my intrepid team. These are my patient safety liaisons. And you can see they're all spread out regionally. We kind of joke, it looks like Molly's trying to play a bad game of Risk and take over the whole state. But they all have about the same number of facilities, I promise you. It just looks like that because it's not quite as densely populated in that part of the state. And then I also on my team, I have 3 amazing infection preventionists. And they're available if you have questions about infection prevention, whether it be endoscope processing or an outbreak, or they go out for all sorts of reasons. How to report something. They're having difficulty understanding your infection data. The PSLs, anything about, doing education on all the patient safety topics, helping to investigate events, understand some of the nuance of reporting. I guarantee any one of them would be just as happy to have that 3-hour conversation with you offline as I would. I have their contact information here. There's my phone number, my email, and you can see there, if you know which region you're in, it's all divided by county. The contact information for each of them, and I'll leave you to slide up for just a few seconds so that if you're looking for someone in particular, you can write that number down. The other thing, if you ever need to find them, if you, again, on our website, you can Google Patient Safety Authority, or it's, I think it's patientsafetyauthority.gov. It might .pa.gov, I believe, actually. And if you go out to the website, there's a Contact Us tab. And if you click on that, you'll be able to open up different tabs. One of them is liaisons. One of them is just our general resource account. And if you email that general account, honestly, they're going to get you to the right person. You just have to let them know where you're from. So there's the last 3 of the 8 liaisons that we have. So with that, I actually got through that a little faster than I thought. What questions do you guys have for me?
And Michelle, we do have a few questions that came in while you were presenting in the chat.
Okay.
So I can read those and we can get started with those and then open them up, see if anyone else has any questions. So first question is, the NCSBN reports that over half of errors are failure to act rather than making a mistake in actions. How are those reported? In exactly the same way. So we do not delineate between an error of commission or an error of omission. We see them in the same way. They're all events. And like I said, we don't even delineate errors from non-errors. Sometimes there's just bad things that happen. So, if a patient comes in, like a 13-year-old lap appy,
and they develop malignant hyperthermia, and they have absolutely no risk factors for malignant hyperthermia. They have no reason, no family history, nothing that would make us, that we somehow missed it. Sometimes those things just happen. That's still reportable. And that's actually reportable as a serious event because there was harm to the patient. So we don't even delineate error from non-error, much less commission from omission, at least not as far as reporting goes. Now, internally, when we do our analysis, there are certainly analyses where we would take that into account, where we're looking for different trends or how things are happening, that our recommendations may be different depending upon that.
Okay. And then the next question is, how are incidents handled and reported in the school nurse setting?
So school nurses do not need to report events. Schools, dental offices, physician offices and clinics, urgent cares. Like there's a lot of different settings where you would see a nurse where they're not required to report.
Interesting.
Yeah.
Okay, next question. How are you funded?
Ooh, that's a great question. And it's the facilities. So every year, as part of the assessments that facilities pay into Department of Health for their licensing, there's a small surcharge on that that funds our work. So we, all of our financials are public. You're welcome to look. I want to say our overall operating budget last year was around $7.5 million, which worked out to right around like $140 or $150 per bed. So if you're an ASF with 2 rooms, you'd be paying right around $300 a year for us. So in the scheme of operating budget for any one facility, it's not substantial, but added up, it's enough for us to do our work.
Okay. Next question, does the Act cover home care, home health, and hospice agencies?
So the Act itself does not. However, if they are licensed under the hospital license, they very much could be covered. So I know, for example, I said like physician clinics don't usually have to report. But I do know that there are some that are licensed under the hospital license, and they do have to report. So it all kind of depends on how your licensing falls. And I'll be honest, like I think each one is probably a little different, and I'm not going to try and make a general statement that's always true, because I think that's probably likely to get me in trouble. But so I would say potentially, but there is not a specific call out for them in the Act.
Okay. Well, that is the last question in the chat. So now we can open it up if anyone has any questions they would like to ask, or feel free to add them to the chat and I can continue to read the questions.
Sure. And I see there Kathy Reynolds, and I know Shirley Dominic was on earlier. I don't know if she's still on. Are 2 of my team members who I talked about, who had their pictures up on that slide before. You can go back to their pretty faces. I saw that they were on, so that's kind of exciting. They can unmute themselves and answer whatever questions come in too.
Yeah. Team effort.
On the spot, but totally. No more questions? Did I just do that good of a job? You guys don't have any questions?
You did a great job. I'm going to put the survey in the chat for anyone that is ready for that. And then, like I said, I'll also email that out tomorrow.
Perfect.
And if Michelle, if you're finished, if people need to run, that's fine. We can stay on for a couple minutes in case anyone wants to stay on and chat.
Here's another question.
Oh,
Are events more likely in certain types of hospitals, e.g. higher risk? Yeah, different facility types. Certainly we see different mixes of events. If you have a particular interest in looking at like your peer group. So say you're at a behavioral health hospital and you want to know about the types of events that are happening in behavioral health hospitals. We can certainly like meet with you and go over some of that data. Either, like I said, either the main contact number to the, or email to the authority, or to your appropriate PSL. And we can help you with that, because there are, obviously in an ambulatory surgery setting, we don't see as many falls or pressure injuries. We don't see as many lab events or, things like that are like monitoring. But we would see more like surgical complications or things involving like sterile procedure types of things. So, facility type very much plays into the types of events we see happen. And then our staff injuries reported are just patient. So there could be situations in which a staff injury would be reported as an infrastructure failure, but we at the Patient Safety Authority wouldn't see those. We only are looking for patient events. We kind of joke it's the patient safety reporting system, not the staff safety reporting system. Because it's things that involve the clinical care of a patient. So some of those could potentially be infrastructure failures. But for the most part, we're not going to see these.
Great questions.
Mm-hmm.
Anyone else?
Well, thank you everybody for taking the time to join me.
Thank you, Michelle, so much for joining us. I hope you feel better. And like I said, everyone, I'll send out the survey tomorrow again. Thank you so much for coming this afternoon. We really appreciate everyone's attendance today, and we will see everyone soon.
Okay. It looks like there was another question that came in.
Oh, yes.
About
can the individual nurse file or just through the facility?
So the general reporting would just be through your facility, because it's the responsibility of each facility to look at the events and investigate them and determine where they fit. Like I said, some things might not be reported. Some things, if there's harm, are going to be serious events, and then they need to send a letter. But as far as the anonymous report goes, if you've submitted that report at your facility, you certainly can submit that anonymous report then to us directly. So that's your option, to do that to us directly.
And now lots of thank yous.
Lots of thank you.
Presentation.
And you're welcome. So follow us on our social media. There's all our. And truly, again, like if anybody wants to talk offline in more detail, we love to geek out about this. So
okay, well, we really appreciate that. And Michelle, I did have one person